Greetings. I'm Dr. Michael Kuhn, and I'll be your moderator for this webinar. The webinar is the work of arthroscopy, autologous chondrocyte implantation with MACI. I'd like to thank you for your participation and attendance and hope that this interactive webinar can be of use for you in your practice and your patients. Next slide. So just a few housekeeping notes. Please remember to keep your audio on mute unless you're speaking. And we encourage questions. If not, we'll ask you questions. This is an interactive webinar, and please, when you have questions, type them into the question and answer box at the bottom of your Zoom screen. We'll be called on about your questions by our panelists. And at that time, we encourage you to turn on your camera and unmute yourself when the question is being discussed. We may take these as we go, or certainly we'll try to answer as many as we can by the end of the program. Next slide, please. As I mentioned, my name is Michael Kuhn. I am the moderator of this session. I'm an orthopedic surgeon and a sports medicine in private practice in Middletown, Connecticut at Middlesex Orthopedic and Spine Associates. Just a bit of background on me and autologous chondrocyte implantation. I've had the fortune in my practice to use this in all forms, starting with Carticel in the late 90s and progressing to the current MACI product. I started implanting it immediately when it became available in the United States 10 years ago, and shortly thereafter started to try to transform this from an open technique to an arthroscopic technique, which I started doing in my patients in 2018. I've been part of the process of developing and implementing the product that you're going to see and you're going to experience. And we hope that you find it to be a very successful tool for you in your operating room, reliable, reproducible, and to give great outcomes and results for your patients. I'll turn it over to the rest of the panel to introduce themselves, starting with Dr. Brian Godshaw.
Hey, I'm Brian Goudshaw. I'm at the Ochsner Andrews Sports Medicine Institute, which is in part of the Ochsner Health System in New Orleans. I have been using MACI. I was trained on it when I was a resident at Ochsner with one of my former partners, and unfortunately, he changed practices. But I got to kind of take over his practice from a cartilage standpoint for the last couple of years. So we've been using a lot of MACI down there. So I'll go ahead, Dr. Golden.
I'm Yuan Golan, joining from Northside Hospital in Atlanta. I also work with the University of Georgia. I've been expanding my cartilage practice as well as osteotomies over the last several years, and really found MACI Arthro to be a new and useful tool in our toolkit.
Great. I'm Monica Sheridan. I'm a physical therapist at Excel Orthopedic Specialist in Woburn, Massachusetts. We work with a large amount of physicians in our practice, so our PT group gets to see quite a bit of post-operative cases, in particular, a fair amount of MACI, because we not only have Dr. Zarnecki, who does quite a bit of MACI procedure, including MACI Arthro, but we're in a very busy Boston area where there's a lot of different surgeons doing this procedure. So.
Next slide, please. So disclosures that we have to present. The presenters are paid consultants of Vericel Corporation. The information that's provided does not constitute medical advice. The information that you'll hear discussing surgical techniques and the rehabilitation are general guidelines for your use. Obviously, individual results will vary among your patients and depend upon many factors, some of which we'll discuss. A patient's healthcare provider should consider all the circumstances around the patient when considering MACI, like you would do with any surgical procedure. Make sure it's the appropriate indications for your patient. Next slide, please. What are the indications for MACI? Well, MACI is autologous cultured chondrocytes on a porcine collagen membrane. Basically, a patient's cells implanted on a membrane so they can be delivered to an articular cartilage defect in the knee and then allowed to grow and expand. It's an autologous cellularized scaffold product that's indicated for the repair of single or multiple symptomatic cartilage defects of the knee, which you'll see in some of the case studies today, with or without bony involvement. Limitations are its effectiveness in joints other than the knee has not been established at this time, as well as the safety and effectiveness of the MACI in patients over the age of 55 also has not been established. Next slide, please. Contraindications are not many, and some of them make sense. MACI is contraindicated in patients with a hypersensitivity to gentamicin or other aminoglycosides, products of porcine or bovine origin. Obviously, we don't want a membrane going in that's the patient's reacting to. And what I call is some of the more common sense ones. This is not designed for those patients with severe osteoarthritis, inflammatory arthritis, and inflammatory joint disease, uncorrected blood dyscrasias, or patients who've undergone other surgeries, with the exception of ligament reconstructions and procedures to prepare for the MACI implant. And it's also important to remember that you can do this in concert with other arthroscopic and open procedures. Malignancy is always a risk whenever we're doing anything, and the risk of MACI in patients with malignancy in the biopsy or implant is unknown. What's that mean? Well, you're taking a small cartilage biopsy from their knee, and in theory, could transplant that to another area of the knee. I would think this risk would be exceeding low, but it is certainly a risk we need to discuss. And as well, patients undergoing these procedures are not routinely tested for transmittable disease. It's going from the patient to the lab and then back in the patient. So all these products carry a risk of infectious disease. Patients with pre-surgical comorbidities, including localized inflammation, infection in the joint or soft tissues around, uncorrected meniscal or ligamentous pathology that you're not going to fix at the time of surgery or before, and misalignment should be assessed prior to or during your MACI implant. And finally, one of the things you'll note when you get these is the product sterility is not completed on shipping of the product, but it will be by the time you are receiving the cells in the lab. So final sterility tests will be available for you at the surgery, but are not available at the time of shipping. Next slide. Adverse reactions are what I would call fairly common anytime you're doing a surgical procedure, but MACI is not excluded. Arthralgias, tendinitis, joint swelling and effusion, back pain are certainly some. The more serious are considered are arthralgias, cartilage injury, meniscal injuries, arthritis, and of course, treatment failures. When we talk about populations of these patients, we discussed before that it's not tested for patients over the age of 55, and certainly the use in pediatric populations has not been established. It's also not recommended for implantation during pregnancy, and patients who are breastfeeding, the safety has not been determined. And obviously, if there are any side effects, we want you to contact the Vericel hotline or the FDA to report these. Next slide. Now for the real reason we're here, and now that we got over the disclosures, I'm going to turn this over to Dr. Godshaw to talk about the technique and implantation.
All right. Thank you, Dr. Kuhn. We go on to the next slide and we'll get started. So we'll start first just by talking about MACI. In general, as Dr. Kuhn said, MACI is indicated for adults aged 18 to 55 that have grade 4 full thickness chondral defects with surrounding borders of healthy and stable cartilage. It can be done with bony involvement. Ideally, it's without bony involvement. Traditionally, it's been an open procedure, and you could do this in any location in the knee, as long as it meets the appropriate sizing criteria. There are pros to doing it open that you could really access anywhere. But we're here to talk about today is the MACI Arthro. And this is for slight defects that meet the sizing criteria, but also usually slightly on the smaller side just to do the instrumentation, which we'll go over later. And this could be done anywhere in the knee that you could access arthroscopically. It's originally designed for the condyles, the medial and lateral femoral condyle. It could be done in the trochlea, the plateaus, and as well. But it's really wherever you could access with arthroscopy. Can we go to the next slide? My Cartilage Care is a big support system that's set up to help the patients and really the physician through the whole process, starting as soon as you talk to the patient initially about the procedure. These patient coordinators can reach out to patients, offer support and education, help them guide them through the process, may have reminders to talk with their surgeon about follow-up. These patient coordinators are not selling or providing medical advice to the patients. They're just simply there to help ease them through the process. There's a support service, which I think is one of the great things about the My Cartilage Care that could assist patients with their copay. Um, as long as they meet certain criteria, being adult patients undergoing MACI implantation to repair that cartilage damage. I've had several patients that use this, and it definitely helps make that second stage, the implantation stage, much more feasible for them. They'll help coordinate cases, help run things through insurance. If there's any issues with that, they will help the pre-authorization team at your hospital or your clinic obtain insurance approval and can help clarify any questions they have. And finally, from the physician side, there's reimbursement operation act centers that'll help with claims and appeal negotiations and also onboard new facilities. So it's not just from the surgical aspect, from the biopsy and the implantation, but they help take, the My Cartilage Care side takes care of everything behind the scenes as well. So we go to the next slide. Going with the insurance aspect of this, as I think all the surgeons on here have realized over the last couple of years, insurance approval has become more and more of a headache for us. Fortunately, MACI is approved in the vast majority of cases. 96% of all MACI cases are approved by insurance. 90% are approved initially on initial submission with about a 1 month turnover. Of the 10% that aren't, 6% are actually approved on appeal. So that gives us our 96%. Some of them are not appealed, but only 1% are denied after appeal, which is a very low number, making this, at least for me, a really good procedure to go with because the approval rate's really high. Sometimes, we worry about getting approval specifically for patella cases, but these insurance approval rates mimic the overall approval rates, with 90% approved on initial submission and 6% again approved on appeal. So it's a 96% approval rate in the patella as well. We go to the next slide. Probably the hardest thing I talk with patients about MACI is that it is two procedures. So it's two different hits to the quadriceps that we have to rehab back. Two different times the patient has to go under anesthesia with that lag time between the two procedures. It's, could be extra time out of school, extra time off of work, and this overall longer recovery process. But I think this study from Ohio State really did a good job explaining, why we have to go ahead and put these cartilage cells back in. And, as Dr. Kuhn says, it is the patient's own cartilage cells that we grow out and get put back in. And sometimes these patients do feel significantly better after that first surgery. You kind of stabilize the articular cartilage borders. They may not have the chondral debris floating around at their knee. You could address any concomitant pathology, such as meniscus things or inflammatory synovitis during the initial surgery. And I've had plenty of patients come back after the first surgery and say, "Hey, doc, I feel really good. Do we need to proceed with the second surgery?" The short answer, I guess, technically would be no, but I always quote this study and say, you don't have to, but if we wait, the longer we wait, we know these lesions are not going to get smaller, and they're probably not going to stay the same size. In fact, they're actually going to get bigger. So in this series of 111 consecutive patients that went from biopsy to either ACI or MACI, 16% developed a new high-grade cartilage defect that would meet criteria for MACI implantation. And the lesions that they measured at the size of the biopsy also expanded by about 0.6 centimeters. So what they determined over the 6 month time from biopsy to delay is it's about, zero point 0.1 square centimeters per month you delay. And the issue you really don't want to run into with your patients, you don't want to take the biopsy and have your MACI implant arrive at your surgery center for the second stage that the patient delayed and delayed. And then you get in there and you don't have enough of the cartilage to put back in. They've developed new lesions or it's gotten a lot bigger. So, I think this is an important thing that we could educate our patients on, that these lesions are only going to get bigger. And the second stage is really kind of what's going to the long-term solution to treat their disease. All right, we go to the next slide. In order, for MACI to be successful, just like any cartilage restoration procedure, there's multiple things that go into it. It's not just the cartilage. We have to take into account multiple patient factors. What's the integrity of their meniscus in that compartment? We want to make sure we have that meniscus cushion and that bumper there. How about their ligaments? We can't have an unstable knee. If we put this in with an unstable knee, there's a higher chance that we don't have good outcomes with cartilage surgery in general, as well as what's their alignment. There's lots of evidence showing that if we're working in a medial compartment and someone's slightly varus, there's increase in a lot of the inflammatory markers, IL-6 and IL-8, and some other things that could be chondrotoxic. And by offloading that compartment, you decrease those inflammatory markers, which are only going to create a more favorable environment for cartilage healing, which would really give our patients the optimal outcome with MACI. So it's important to consider all these factors and address them either at the initial biopsy stage or at the implantation stage, so they have the best outcomes. We go to the next slide, and I think this is where I will hand it off to Dr. Golan.
Thank you, Dr. Gottschall. So I'm going to kind of quickly highlight some of the new techniques and equipment that Vericel has provided for us. So looking there on the left, this is a lesion that we've all seen, and Vericel has now made it possible to treat this kind of circumscribed condyle lesion arthroscopically. So this cannula is very useful, and I've just given some quick tips, and we will show a video later. I think the first thing is that we need to have direct access to our cartilage lesions when performing an arthroscopic MACI procedure. And so when I was training at Pitt, Dr. Freddie Fu always used to tell us, make as many portals as you need, take as many looks as you need. And I think that's the take-home message here. We're used to coming in at kind of an angle 45 or whatever it is, not approaching things straight on. But you really want to get this hugging the patella tendon and play around with your spinal needle and make sure that that cannula is straight on. And what it really comes down to is its access and visualization. If you can do a knee scope, you can do this procedure. Next slide, please. So in terms of defect preparation and debridement, I really think the hardest part of a MACI arthro case is that first slide to the left, which is putting in the arthroscopic cutter and opening it without creating a new cartilage lesion that you have to fix. Obviously not something we want. I like to, another small tip, outline mine with a marking pen. Sometimes it does bleed a little bit because there's water in there, but the idea is to make a stamp. And then another key point that I show when I'm kind of showing the trainees is to over resect just a little bit, just as you would in an open procedure, because there's plenty of cells there, and being a little too big is much better than being a little too small and not being recessed enough with stable borders. Looking at the center, three main instruments for preparation of the defect. From left to right, the ring curette, the box, and the rake or hoe. The ring curette is still my workhorse. Be mindful of the fact that these are very, very sharp instruments. And then again, that take-home message of being far medial and far lateral. So taking that rake or hoe to the right, that thing is almost at a 90-degree angle. So what I like to do is if I'm working in the left of this picture, I would be coming in from the right. And then when I get midway down the lesion, I would switch. And I'm often viewing straight on through the portal that's eventually going to house my cannula. And then to the right, we see that in a dry arthroscopic environment, we have an applicator. Next slide, please. The preparation is really easy, just as easy, if not easier than the open procedure. You have these different sized ovals. Currently, MACI Arthro is limited to an oval shape in one of three sizes. Bottom left for your cutout to make sure you have correct cell side up. And then to the right, this V shuttle is really quite useful. This allows us to load on two antennas. And again, I'll show this in a video in a little bit. But the key point or kind of the pro tip here is to be a little high, because it's very easy to pull your lesion down. If you started a little higher up, it's kind of hard to work against gravity and pull it back up. Next slide, please. And so remember, it's access and visualization. So you want to take a lot of time, almost like that first time you did a rotator cuff in residency, where you get everything out of your way so you can see. I use mulberry knots. I use passing stitches. I'll even take my coag and kind of try to pull and then tension the tissues around, similar to techniques that are often used in hip arthroscopy. And then once you have that, you go dry, cannula goes in, and it's like an open MACI almost. We fill it with our fiber glue. E-shuttle allows for that deployment, again, a little high. And then we have this nice kind of silicone and to do final manipulations. Next slide, please. And I'll hand this off to our physical therapist.
So before we jump into that, I just wanted to take a second here to, the panelists here have done these cases, and we see the nice little how it looks all great and good on the animated slides. Dr. Golan, you mentioned some portals and Dr. Fu's teaching, and I asked the panelists, we're so used to being myopic in my mind, and a lot of doctors, and just using scoping through the lateral working medial and maybe flipping it back and forth, but when you all are approaching these lesions, specifically like as we're talking about a condylar lesion here, do you have any other tips on portals or any go-tos that you all seem to find effective in, specifically with preparing the defect?
I'm sure to start, I think it's just really reinforcing the idea that instead of coming in at kind of 45, I'm almost trying to come in at a 90-degree angle. And that really allows me to get a sharp edge down. And I do not hesitate at all. Like if I make my normal, superior lateral incision, come in, I have another parapatellar. If I make three or four portals, I think you make as many portals as you need and don't hesitate for a second would be my advice.
I think I would definitely echo that. We all want to do it just through our two standard portals for cosmetic reasons and whatnot, but I don't hesitate to make another one or switch back and forth. I know, Dr. Golan, you said you like the ring curette. I think that's a great one. I actually like the square one maybe a little more because it's double-sided. So you could kind of flip it around if you have to work on it. I think it does a really good job with that. So
Yeah, and I echo those comments too. I am that myopic guy, and as I was doing these initially, I talked to colleagues and some of these guys about other ways to do it. It's like, yeah, don't get stuck with a portal. I find that especially when I am harvesting when I'm preparing the defect. I find sometimes just a direct medial or direct lateral portal, and then I'm actually bringing the curettes in, if you will, tangential to the articular surface, but with the cutting surfaces of the curettes perpendicular to the defect, so I can cut and pull, sort of like a rake maneuver, and that's sort of helps. But it's working back and forth as you hear, with like anything in these cases, you get stuck, you're trying to get to something, you just can't change position. I find changing positions of knee flexion help as well. And certainly having an assistant in the OR to help. Um, do you guys have any concerns or I've had some patients sent with, I'm concerned that it's a posterior lesion. I'm not just going to be able to get to it. Do you find it more difficult, easier arthroscopically? What have you found when you're getting to these, lesions that extend a little more posterior?
the medial ones that are posterior, I think, are much easier arthroscopically. The lateral ones, depending on how you're scoping, I think could be tricky, doable but tricky.
I would echo that, and I'd also say I think there's sometimes a hesitancy to try something new in a lesion that might be difficult. I think talking about the worst case scenario is you put a scope in, you just can't get access, you extend it and make an arthrotomy. So I think
Mhm.
there's potential huge benefit from trying it arthroscopically, and if you can't, an open MACI is a great procedure too.
Yeah, I think that's a great feedback in Pearl. Again, you're right in the area of your mini arthrotomy if you're going to need to do it. That's what I tell doctors when you're trying this. Pick one that seems to be staring you at the face for your first one. And if it's not going well or you're not getting the access you need, then again, you can always live to fight another day, and you're just transforming your portal into a mini arthrotomy and go at it from there. Anything specific about the cannula size? I know we have a 3 and a 4 centimeter cannula. Any go-tos for you guys? Or I tend to just always use the bigger cannula, but that's just me. Anything from any, I'll take that as we just pick it based upon
I
what's
think I
going on.
think we cut out for a second
Yeah,
there.
you
Sorry
cut
about
out there for a
that.
second, Dr. Kuhn.
Yeah,
Can you
but
hear?
about the cannulas, I would say the same thing. I usually use the bigger one unless it's a very small patient. I might trial the smaller one, but I agree with you.
Yeah, I've used the both. Southeast Louisiana doesn't have the best patient population from a body habitus size sometimes, um, but muscular patients that are often getting these. But yeah, I think the force is more reliable.
And these are 15 and 18 millimeter cannulas, so obviously they're bigger than the
Mhm.
ones we're normally used to using. So I think I agree with that as well. Well, I think, equally as important after we implant this stuff is making sure these patients receive the proper rehabilitation, which, as we know, is key. So I'm going to turn this over to our expert, Monica, to share some guidance and insights on rehabilitation.
Thank you, Dr. Kuhn. So yes, today I'm going to just be going over a little bit more about the rehabilitation program. I'm just going to give you a brief overview, not get into the nitty-gritty, but just some considerations here on this slide, just as we think about planning for our patients, because I think that's important with MACI. It can be very different when it comes to different defect types, different patients. So it's good to kind of rehab plan. Adherence is obviously important. We want our patients to adhere to the protocol along, obviously the PTs need to be adhering to it as well. It's designed there to be there for a successful outcome. So obviously we don't want patients who are going to be non-compliant, which that's typically screened, hopefully. Patient and surgery specific factors. This is important to kind of think about ahead of time. Our individual patients obviously affect rehab, and especially when it comes to cartilage repair. We have different things such as, the BMI, activity level, age obviously factors in when it comes to cartilage repair. All their different medical history, surgical history. These are all things we want to consider because they all can impact obviously their outcomes. Surgery specific factors. This is obviously we want to know if there's any concomitant procedures performed, but we also want to know about their defect a little bit, just understanding where it's in, if it's tibial femoral, patellofemoral, that's obviously a given, but even just the little nuances, how big it is, where does it articulate in the joint, it's helpful to kind of understand that as we plan things out. That's where getting the op report and maybe communicating with the surgeon is very important to understand those little details, especially with the complex patients. I really like to touch base with the surgeon, make sure everyone's on the same page. They often have other insight as to that particular patient, how they felt everything went. And it really can be very helpful when it comes to their rehab. I think they want to make sure those patients are well taken care of too. Goal focused progression. This is obviously important with any postoperative case, but I truly think cartilage is specifically even more important when it comes to goal focused progression. It needs that gradual progression. It needs that, we want to make sure patients are meeting the goals of each phase so that they are ready for that next step, not just, jumping ahead just based for timeline. Our patients are going to vary quite a bit with MACI, so that's really important to not just kind of stick them in that cookie cutter timeline. We obviously want to avoid excessive load and weight bearing. This is important, obviously, not just in the beginning when we have those restrictions, but even later on as we progress into the protocol, we need that gradual increase in load again. That cartilage needs to be taught to withstand more and more load as we go. So we want to make sure we're increasing that gradually and never really jumping ahead. And that's where we also want to monitor symptoms all along the way, such as pain, swelling, and other mechanical symptoms. Even in the beginning, when we might expect some of those, that's obviously something we want to not be increasing. But also, even later on in the protocol, as we're progressing exercises or patients are progressing their activity, we want to make sure we're monitoring those symptoms and backing off accordingly if necessary. I always educate my patients to make sure they're monitoring those symptoms too. Oftentimes, patients may not even feel discomfort or pain or swelling until the next day after a new activity. Cartilage is aneural. Oftentimes, they don't feel it during, or maybe they'll just be in response to an activity. So they should be learning to kind of monitor their own symptoms as well. Next slide, please. So this is a general overview of our rehab protocol, and I'm just going to kind of touch upon each phase just so you guys can have an understanding as to the different functional goals we're going for in each phase and just the general milestones that we're hoping for our patients to reach as well. Cartilage, when it comes to these defects, we want to understand what's happening in that defect as that implant is growing, as that new cartilage is forming. And that's, I think, my biggest take home when it comes to rehab is if you understand what's happening in the defect all along the way, you'll understand why they have these restrictions or why, we're holding off on certain things, so that it's not just a matter of what they can do, it's more what should be doing for that cartilage. So the first phase, it's roughly about 3 months long. Again, that's all relative, but we're basically trying to get them back to achieving their routine, their daily life. This is where it's all about range of motion and progressive weight bearing. It's going to vary based on tibial femoral versus patellofemoral, obviously, with those different guidelines. But everyone, we're trying to get that full extension by weeks 2 to 3, and we're trying to get that full flexion hopefully by week 7 to 9 as well. This may vary a little bit, and we'll talk about this when it comes to MACI arthro and in certain cases, but we're steadily getting that range of motion, and everyone should be getting that motion by, hopefully week 7 to 9. And we're also hoping to get that full weight bearing by then as well. That's obviously going to be a little bit different depending on the defect as well, but everyone should be getting to that normal gait and that full weight bearing and free from devices by the second, half of this phase and towards the end of this phase. That's where some patients too, they're maybe if they're more complex, we're really focusing on gait. We're trying to get them proper mechanics. Some patients get to this right away, but some also have not been walking normal for quite some time if they've come to this MACI with a lot of history. And so at the end of this phase, they're hopefully back to normal daily activities, just meaning ADLs, normal mobility, maybe with a little bit of assistance, back to sedentary work, driving, etc. So as we progress into that second phase, this is where we're starting to focus on building strength. And I just want to touch upon that this defect still now, we have that new cartilage forming inside that defect. But around 3 months, it's about half full and it's progressing to fill that defect by the end of this phase, so around 5 to 6 months. But it's that softer cartilage, that, immature kind of putty-like consistency. So it's not ready for heavy loads and it's not ready for a lot of, that type of activity. So we're progressively working on these movement patterns and we're getting them into closed chain exercises. Patients will vary in this phase. Some will get this pretty easily. Some are going to take longer. Maybe they're more complex. Maybe they have larger defects, multiple defects. It all depends on each person as to kind of what they're ready for. And so we might have to take a little bit more time or progress range of motion with these exercises a little bit slower for some. But by the end of this phase, we're hoping to get back to lower impact activities. So golf, yoga, cycling, those types of things. And so then we finally move to the be active phase. And again, roughly 6 to 9 months, increasing the difficulty of things at this point, because we're hoping that now that cartilage has filled into that defect and we're trying to increase the durability of that repair tissue. So that means teaching the cartilage to withstand more loads by slowly applying more. So increasing difficulty of exercises, like I said, but also starting to work on maybe with some of these patients, if they're ready for it, a little bit more sport specific type things. Again, if their strength is there or they have a less complex knee. And then we're hopefully progressing into some of those higher level activities for some. Some patients might take a little bit longer. Our more complex patients, maybe more 9+ months for some of this stuff. And again, it all depends on each case. And so that's where it turns to when are we ready to return to activities? So no matter what time frame that is for these different patients, we're looking at these main factors. We want to make sure the graft is mature enough. So, we don't typically see repeat imaging, but if there's, they're able to do the components of their activity and they're not having symptoms and they're able to show that that graft is handling that, that's important. And then we want to make looking at physical, readiness. Obviously, this is where return to sport testing is really important. Objective data is key. And then just if there's any psychological elements to that, we can always use those different assessments if we're not sure. And then finally, obviously, the surgeon needs to weigh in and make sure that they're cleared for their return to activity. So I'm going to turn this back to Dr. Kuhn, just because I know he wants to maybe talk about, when it comes to if there's any changes in guidelines with MACI arthro, or we can get right into those case studies, but I'll turn that back to you.
Yeah, certainly. Thank you. And just so we make sure, because I know everybody wants to see how this works and what it looks like in real form, let's jump into the case studies, and certainly as time permits, we'll get back and discuss some rehab stuff at the end.
Sounds good.
All right, great. Well, thanks. So I appreciate the opportunity to share this case. This is a 34-year-old gentleman who's doing a dyno jump while bouldering. I didn't know exactly what that was, but it didn't sound fun. So he presented to the ED. He was diagnosed with patella fracture, patella dislocation, did some kind of reduction, pulled on it, a big effusion, and followed up with my partner. She recognized that there was a large Lockman and ordered an MRI. So some preoperative images, and I won't obsess on all the details. We can see a high grade 3 distal MCL there, as well as an ACL tear lots of energy from falling off of the bouldering wall. And then kind of the line right through it helps us out, as radiologists sometimes do. But there's a large cartilage lesion on the medial femoral condyle, just full thickness. So zooming in and taking a look at that, the summer is a 34-year-old male with an ACL tear. He did have meniscal pathology, as well as a medial femoral condyle lesion and distal MCL. So what are our options? And the specific question becomes, is this a single or staged approach? When and how to address the MCL, which we talked about quite a bit. He was actually getting married several weeks after the injury. So that helped us make the decision of he didn't want an MCL repair or reconstruction right then. We are going to try to non-op that, and then how to treat the cartilage. So after discussion, active guy, wanted to get back to rock climbing and other sports. So we decided upon a staging biopsy, PT for stiffness, bracing him for his MCL, and then going ahead with a staged quad ACL, MACI arthro, and again, evaluating his MCL intra-op. So one kind of piece of advice that I got when I was starting that I'd like to pass on was to have a low threshold for performing staging scopes. These are really quick to do. There is some quad breakdown, as was discussed earlier, some quad that needs to be turned back on. But I think given that the patients are immediately weight bearing, this is something that can be done quickly. It can give us the lay of the land, and is really something I would build into my practice if I was starting over as a cartilage surgeon. And this is a biopsy being performed in real time. And really, you can do this several ways, but I use an arthroscopic gouge, just coming to the notch. I like to kind of outline one of the sides of the notch. Really no difference there. Obviously, make sure we're not getting into the cruciates. And then once I outline it, it's just a simple drag and pull. What you do afterwards, whether you kind of just debride it and microfracture it, is up to you. But and I'll speed this up so we don't have to watch me fumble around in here. But this is 3-4 minutes maybe, and we're just going to get into the lesion. Obviously, we want to make sure we don't veer into the condyle, and then we're going to start pulling down and pulling the lesion off. And so, excuse me, start pulling the lesion off. Get this. Make sure your rep checks that you have a sufficient bone, and then you're pretty much done. I oftentimes come back to a little bit more to make my rep Bob happy. So this is just another preview of when a staging scope is ideal. So I'll run this while I'm talking. So this is a Australian national team soccer player who ended up coming to the United States for college. And originally she had a TTTG that suggested that we might just be able to treat her with an MPFL after debridement. But you know what? We decided to do a staging biopsy. We weren't even sure if she needed cartilage. And you see, once we do the staging scope, this really changes the plan. So initially I'm thinking maybe just a debridement, maybe just an MPFL. You can see she has trochlear dysplasia, really maltract. She's had a previous lateral release. And so with that large cartilage lesion that I can see, it's really changed my plan. And what I mean by that is I've gone from maybe a loose body removal if there's something floating around to staging a cartilage lesion, but then also talking about, do I need to do a TTO here? Do I need to consider something with a trochlea? And what she ended up getting was an MPFL and a TTO, along with a MACI and what's called an entrance plasty, which is a technique that Scott Galogli taught me. But doing that 10-minute biopsy, which really didn't put her out for very long, it really gave me a lot of useful information. And whether I was going to go with an osteochondral allograft or MACI or other form of cartilage implantation, I was able to look at it, assess, and have a true plan before I got that expensive and time-consuming process started. So going back to our case of our ACL tear, this is us harvesting the graft, and I think everybody on this has probably seen. So I do a standard quad harvest through a transverse, but you can do a vertical incision as well. And then, sorry, my control. Is someone able to play? There you go. So coming through and showing the meniscal repair. I apologize for the difficulty with the video. And then just showing the standard part. So let's get to the lesion. And here it is approaching the medial femoral condyle. So remember, the first thing is access and visualization. So I want to get straight on. I'm going to do a little bit of debridement and notice that there's a lot of kind of hanging tissue in the periphery right now. So I like to use these mulberry knots or passing stitches. This is a PDS, and you really want to place as many of these as you need. And the point is to get that capsule out of the way. So I tie a knot, I pull it back through, and you just kind of tie and clamp it to the drape, just like you might have been taught in hip arthroscopy. And take as much time as you need here, because if anything snags right now, it's definitely going to snag when you start doing the MACI, and certainly when you put your implant in. So here's me getting my localization. This is that cutter that we talked about. I try to outline it, and the marker sometimes does go all over in the joint, but it kind of gives you a base of resection. Remember, you want to take a little too much and not too little. And then notice how I'm working from far medial and far lateral, as Dr. Kuhn advised, switching back and forth constantly to make sure that I perform my resection, taking my time. And then this is another trick I like. I like to make a little template so I don't have to put that cutter back in and out. And even though this doesn't quite fit, it basically allows me to check without introducing the cutter again, without having to open up that big cannula and say, all right, I'm almost there. I need a little bit more taken from the top or wherever it is. So just the PDS pass through a little S mark that I made allows me to do a quick check. And all right, I'm going to come back, resect a little bit more, because you definitely do not want to put your implant in there, right? Go through all the trouble of preparing it, drying out the knee, and then not having enough. Watching us use our different tools here, and then our implant is almost ready to come in. I'll speed us up there a little bit. Once I'm satisfied here, going to check my template again. And then this is the V shuttle. I do recommend firing this without the implant on it first. And what I mean by that is if these little tongs that push the implant out snag, it's not going to go well. So make sure that you can deliver those free. Then we're going to go dry, put our fiber glue in again from top to bottom, working with gravity. And then lastly, we're going to put our implant in. And I'm aiming a little high here on purpose, right? I think maybe as you get more facile with this, you can get it in perfectly on the first try. But there's nothing wrong with having it a little high and using the nice tools that Vericel's provided to pull this in. I like that position, and then I'm going to cautiously check it. And then another tip that I like is if I'm having trouble getting superior inferior, as Dr. Kuhn recommended, just a little bit of flexion or extension of the knee can really help. And just like open now, here's our final layer, and then we're gonna flex and extend, make sure we like it, and we're done. So take home considerations: make as many portals as you need, really working parallel, but more perpendicular access. And then making sure that we're straight on for the cannula. Remove all soft tissue impediments, knots, taking the electric artery, pulling the tissue over and kind of coagulating it so it crinkles or tightens in that distribution. Be careful with the cutter. I do think you can cause some serious damage if you open that up. And then a dry run with your V shuttle, consider an S-mark template. I'll pass on to Dr. Godshaw.
All right, thanks. That was an awesome case. Nice work. Um, so this is the case of a 39-year-old lady, came to my clinic uh, about a year and a half ago now from today. That we go to the next slide. She had multiple defects in her knee. She kind of had several years, about 3 years of insidious onset left knee pain, mainly medial knee pain. She's Louisiana skinny. And she's a respiratory therapist, of course, at our hospital, which means, always a little pucker factor for me when they work at the same institution. Her main activity, she's a dancer, former higher level ballet dancer, doesn't do that as much anymore, walks a lot. But as is big in New Orleans is Mardi Gras, and there's lots of parades in Mardi Gras. During Mardi Gras, there's not only the floats that we know, but there's dancing crews of people that dance for the miles and miles of each parade because they're not very short. She's in one of those dancing crews that does about 5 to 6 parades every year. So it's probably close to 20 miles of walking every year over the 2 weeks, just walking and dancing at the same time. So this was really starting to bother her and getting worse and worse. She saw me in 2025, right after Mardi Gras. Knee was really flared up and she wasn't really happy with it, just recurrent left knee pain, really on the medial side. We go to the next slide. So we'll just go to the next slide. We'll just go ahead and show the x-rays and just talk about them. So on her left knee, overall, her joint spaces were pretty well preserved. She had a little varus, about 5 degrees is what we measured here. Um, almost symmetric, slightly worse on the left side than the right side. So we go to the next slide. When we look at her MRI, she had a bipolar lesions in the medial compartment with full thickness lesions on the medial femoral condyle, medial tibial plateau. A little bone marrow lesion on the medial tibial plateau, nothing significant. There were no cystic changes on it. And she had a full thickness defect in the central aspect of her patella. She had some anterior knee symptoms, but her main complaint was medial. Just some very dull, vague sit to stand pain was her anterior symptoms. The menisci and ligaments, everything else in her knee looked very good. So we go ahead to the next slide. So, this is what we saw. We went to our staging arthroscopy, which we have some pictures up coming up. She had four, go to the next slide. She had three grade 4 lesions. We see on the center one and the one on the left, there's a medial compartment, full thickness on the left in the medial femoral condyle and the medial plateau, that they were quite sizable, like 25 by 10, I think, on the plateau, on the condyle, and 15 by 25, sorry, on the condyle, and about 15 by 10 on the plateau, and a large one in the central aspect of the trochlea that was 15 by 10. So this was our staging scope when we took our biopsy. Dr. Golan showed an excellent video. I used the exact same arthroscopic gouge and do it the exact same way. I think that's kind of the easiest way to do it. We go to the next slide. So then we planned our second surgery. And as I alluded to before, it's not always about the surgery or about the cartilage aspect of the surgery. We have to take everything else into account. As Dr. Golan had the meniscus and the ligaments, this lady, those looked fine, but she was malaligned, and I didn't want to have a suboptimal healing environment in that medial compartment where you're doing a bipolar lesion. So we added a high tibial osteotomy for her to unload that. So if we go to the next slide, Dr. Golan showed an excellent way to use the template and the cutter, and that's great when you have the perfect lesion really on the condyles. I found it difficult to use on the plateaus, and it's hit or miss for me, at least on the trochlear lesion. So I did it kind of the way, old school way, before the open templates came out, is I just freehanded back to healthy and stable cartilage borders throughout all three lesions, and just use a um, probe with a measuring units on it, and was able to size it. And we used foil templates from a suture packet to actually create these. And you could use the foil templates or the Esmark and cut to match it to put into template as well. Make sure it's the correct size. Fortunately, when I did this case, it was not too long ago. It was about 7 weeks ago. The fellow that was with me was very skilled with arts and crafts, so she was excellent at cutting out our MACI implants. So you could see on the bottom left and right our femoral condyle and our trochlear lesion once we got it debrided back. And if we go to the next slide, we'll show how when we put them in. The hardest one to put in by far out of all these is the plateau one, which you see on the two images on the left, the top and the bottom. When I do this for the plateau lesions, I'll actually leave it on top, leave the foil template on it, and I'll grab the foil template with a crab claw type device and slide it in after you put the fiber and glue down, and you could slide it off. And the nice thing about the cannulas being so big is you can look at sorry, when you're holding the foil in with the crab claw, you can kind of sort of free or another device in to lift the foil off of it, and it lays in, and you put the second layer of the fiber and glue on the bottom. When I debride these, I debride the opposite order I implant them. So I just, from a flow standpoint, I'll debride the trochlea, then the condyle, then the plateau, and I put the plateau in first. And then I moved up to the condyle, put in exactly the same way as Dr. Golan to use the V shuttle, aim a little high and let it kind of slide down if you can. And the trochlear one, I think sometimes the trochlear one's maybe the easiest to put in. You could cut off one of the black little prongs from the V shuttle, and it just lays down really nicely. Especially when I position my patients for arthroscopy, they're laying supine on the bed. I don't break down the foot of the bed. So with the leg extended, for this case, I actually put a K-wire into the central aspect of the patella and had I forget it was my med student or my assistant just pulling up on it, and it really creates a ton of space in that patellofemoral compartment, and it makes it really easy for that to slide right down. So for her, with her rehab, I slowed her down a little bit because of the high tibial osteotomy. And there's different ways you could approach that, kind of the dual procedure part with the MACI implant and the high tibial osteotomy. You could do the HTO or the osteotomy first and then put the implants in. The benefit to that is you don't have to worry about, lots of motion within the knee with the saw and putting the hardware in. when your implants are in. But then you're putting some stress on the osteotomy on the hinge, and you obviously don't want to create a hinge fracture. So I've done it both ways on this lady. I actually did the MACI part first, and then I went and did the osteotomy afterwards, and went very smoothly with that. We don't have any fun pictures of that on the slides. So because I did the high tibial osteotomy, I did slow her weight bearing down a little more than I would for a typical MACI. I had her foot flat weight bearing for about 4 weeks, and then with the goals to progress to over the next 2 weeks to full weight bearing. I locked her in extension. Really, always set the brace on my patients in a little hyper extension because they tend to get a little resting flexion if you set it right at zero. I left her at that for about a week, and then we set her at zero to let her range to 40 degrees and added 10 to 15 degrees a week as she could tolerate after that. I was hoping I could get her in to get some follow up before this, some more recent follow up, but she's not couldn't come in until next week. So kind of long-term outcomes to be determined on her, but so far she's doing very well and progressing appropriately. So we go to the next slide, and we just talked about that. So we can go on to the next one.
Thank you. That's awesome. Obviously, some complex cases and some double black diamonds, as I like to call them, and you guys are good skiers for sure, or snowboarders, whichever you prefer. If there are any questions, pop them up in the chat. But obviously, I have some for the panelists as well. So we see these big cases and stuff, and I said, why MACI Arthro, right? You have this open technique and you can do it, and why would you want to fuddle around and switch to MACI Arthro? So obviously, this isn't the only way to attack these lesions. There's other opportunities to do this through an arthrotomy. And there'll be another presentation on April 21st. You can scan on the screen to register, and you'll see the panel of very distinguished surgeons with a lot of experience to share with you on this procedure in a open technique. Myself and all the panelists would certainly like to thank each and every one of you for your time, for your participation. Uh, I know I speak for myself, but I'll speak for these guys too. We're always available to talk to another surgeon or somebody interested in this to give some pearls and some insights and just to help you get this going in your practice. Thank you and have a great day.